Great. Good morning, everyone. Welcome to Friday Medical Conference. This is actually the last Friday Medical Conference of the year. We'll be taking the summer off and starting back up again in September, so thanks for joining. This is sponsored by Western Montana AHEC, and my name is Robin Moki. I'm the Continuing Education Coordinator with AHEC, and this morning I'm very pleased to introduce Mari Hodges. Mari holds a Master of Science in Medicine in Pain Management from the University of Sydney and a Therapeutic Pain Specialist certificate from Purdue University. She also has an Alexander Technique Teacher Training Certificate. She teaches Alexander Technique in her private practice and also at St. Patrick Hospital here in Missoula, Montana. So please welcome her, and you're welcome to ask questions at the end of the presentation. You can unmute yourself or type into the chat. So welcome, everybody, and thank you, Mari.
Thank you, Robin. I'm very appreciative to have this opportunity to share with you this article that colleagues Tim Cacciatore and Rachel Cohen and I have written together that was published last fall in Kinesiology Review, that aims to address the how and the why that Alexander Technique helps to reduce pain from a modern pain science perspective and in light of advancements in the field. Today, I'll describe what Alexander Technique is. I'll briefly review the shortcomings of a purely biomedical model for understanding pain. I'll describe a contemporary model of pain and how Alexander Technique fits into this new framework. Alexander Technique is a cognitive embodiment practice. It can be practiced in movement or in stillness, including by people unable to do exercise. You could think of it as mindfulness in the whole body in action in daily activities of life. It involves a non-judgmental, non-reactive kind of self-observation with curiosity, as opposed to any attempt to fix anything. It's an embodied learning approach to increasing the ability to self-regulate, including the ability to alter postural state and movement, which to a large degree are governed by unconscious processes. Alexander Technique is not about posture or alignment or imposing either of these, but rather about enabling ease of movement and posture. The Alexander Technique, or AT, aims to increase self-awareness, including awareness of habits and reactions, which can often be quite subtle. So it aims for an increasing ability to observe oneself on an increasingly subtle level. Conscious choice of action, as well as reduced reactivity before, during, and after activity. Promoting dynamic adaptability of muscle tone and functional patterns of movement during everyday activities for efficient and healthy functioning and improved performance of tasks. And finally, improving postural support, which is not, again, about position. There's actually a lot going on underneath posture, and science can tell us a lot more about what is going on underneath posture now. And these things are important in AT. And observationally, all of these things tend to occur together as an organization of the whole body improves. Alexander Technique is not for pain. It doesn't aim to fix anything. It doesn't aim to correct posture. Alexander Technique practitioners use a specialized, non-manipulative manual guidance that they train for at least 3 years to develop, through the practice and learning of the technique, as well as verbal guidance. And these kinds of guidance are used in simple movements of daily life with mindful attention to coordination of the whole body as those are being done. For example, a practitioner may touch a client's neck or back, helping to redistribute postural tone by encouraging a reduction in contraction to allow lengthening of the spine, widening of the back, depending on the presentation. The practitioner might gently invite availability of movement of the head, particularly the atlanto-occipital joint, to promote an adaptive state of tone. So rather than imposing a position or a posture, AT encourages adaptive postural tone. And this is important because of the highly individual nature of posture and motor control in relation to pain. This kind of manual and verbal guidance goes hand in hand with the development of constructive thinking skills. So the skills that are practiced in particular are those of self-observation, non-reactivity, and spatial intention. And I'll describe those a little bit more. And these skills are practiced in quiet posture or in movement, in activities of daily life. For example, sitting, walking, standing, talking, working, any activities that the person does. And AT lessons involve behavioral experiments. And these experiments allow the practitioner and the client to observe how the changes in the client's thinking affect postural tone and functioning in the activity. So it's common, for example, that a practitioner would guide a client from sit to stand in a slow way that helps to alter postural state. For example, by releasing tension or by engaging mentally with the configuration of the whole body. And then both the practitioner and the client observe the changes that happen, for example, in the smoothness of the movement or the amount of effort involved. And teaching usually involves some instruction in basic anatomy as well. So an understanding, for example, of where joints are and how do they work. Here's an example of some typical activities that might occur in a lesson. Here are some of the areas of research that have been done on AT. It's been found that AT helps to reduce back and neck pain. There's preliminary evidence that it reduces knee osteoarthritis pain, helps to improve balance and movement, as well as psychological aspects, such as self-efficacy and executive inhibition and self-care. An example of one of these was a large randomized controlled trial of AT plus usual care compared to usual care alone for back pain. I won't go into the details, but the results were significant sustained improvements in pain and disability compared to massage, exercise, and control. Another one was a large randomized control of AT plus usual care compared to usual care alone for neck pain. And this trial showed significant long-term improvements in pain and disability for AT, as well as acupuncture, and significant improvements in self-efficacy. Self-efficacy being a person's belief in their ability to do things despite pain or to control pain. In talking about pain, it's important to discuss the shortcomings of a purely biomedical model for understanding pain, meaning equating pain with tissue damage, assuming a direct proportional relationship between pain and tissue damage, and the necessity of finding an anatomical source for pain in order to believe that there is pain. So I won't go into detail into this model so much because both Dr. Chris Caldwell and myself have discussed this previously here, except to say that the evidence doesn't support it. It doesn't consider the role of sensitization and plasticity in pain, particularly in persistent pain, and not to mention the invalidation and stigmatization that occur when the search for an anatomical source for pain is unsuccessful. Again, Dr. Caldwell and I have talked about a contemporary model of pain here, but I will touch briefly on this modern understanding of pain as a multidimensional and multifactorial experience that is not just about sensation. Pain involves cognitive, affective, attentional, behavioral, and social aspects, as well as the biological ones. Pain is protection. It's a protective system and a protective response rather than an indication of damage. There's an understanding now that plasticity, sensitization, and plasticity play a prominent role, particularly in persistent pain. And there's a recognition of the involvement of sensory motor disruptions, which I'll talk about, and psychosocial factors in pain, and particularly in persistent pain. Sensory motor disruptions appear increasingly with chronic pain, and growing evidence points to their contribution to the pain problem as well. Sensory motor disruptions include altered sensory processing, for example, reduced tactile acuity, impaired proprioception, disrupted body schema being the mental maps of where body parts are. Sensory motor dropouts, so the sense that something can't be found or is missing, and cortical reorganization, as well as altered motor control and postural control involving an altered distribution of muscle activity, impaired balance, as well as alterations in attention and reactivity. All of these contribute to changes in motor behavior, which can be beneficial for pain in the short term, but lead to long-term suboptimal consequences. For example, if a person is bracing due to pain, the bracing and avoiding of movement can reduce pain in the short term, but may develop into long-term habits that limit movement and reduce sensory input and contribute to hypervigilance, perpetuating pain in the long term. While postural alignment is only weakly and inconsistently associated with pain, posture is better understood as a system that involves postural tone. And postural tone may be much more relevant to the issue of pain than alignment. Postural tone is the low-level background tonic skeletal muscle activity that's actively regulated by the nervous system and that enables the body to sustain postures, such as being upright in gravity. Postural tone is adaptive. It enables us to yield to forces on the body and to resist forces on the body. And it's interconnected. Changes in postural tone in one region affect changes in other regions. As I mentioned, there's a lot going on underneath posture, and postural tone is altered in pain conditions such as back pain and neck pain. There's an altered distribution of activity from deeper muscles to superficial muscles, and there's a reduced adaptivity of muscles to different postures. For example, in back pain, as a person inclines forward, there's a reduced adaptivity of that muscle tone to the requirements of different postures. There's also altered recruitment of muscles. All of this affects the altered motor control and sensory disruptions that occur in pain conditions. For example, in chronic back pain, people often have a distorted sense of their back. For example, they have sensations of swelling or misalignment, or difficulty identifying parts of their back or the whole back as part of their own body. And these changes influence tissue loading, commonly leading to static loading of tissues, and this may lead to increased nociceptive input, increasing the likelihood of pain. And attention and reactivity also have bidirectional relationships with these. And we know that altered neural excitability underlies the altered distribution, the reduced activity, and altered recruitment of muscles, and it likely underlies these sensory deficits, motor changes, and alterations in attention and reactivity. All of these things that occur in people with in many pain conditions. And it's likely that changes in excitability of the neural circuits that regulate tone occur. And these changes are hypothesized to underlie the pain-related motor disruptions that occur in persistent pain. In contrast to biomedical model-based simple stretching and strengthening approaches, it's now understood just how important it is to address the brain and to target sensory motor disruptions, and the relevance of psychophysical interventions such as AT. Advances in pain science have led to novel interventions aimed at recovery rather than just management of pain. These approaches have also been discussed here by Dr. Caldwell and myself, but I do want to mention these two promising therapeutic approaches to back pain that are based on a modern understanding of the role of the brain in pain. And they're showing greater efficacy compared to conventional treatment, and they also have much in common with AT. And these are cognitive functional therapy and graded sensorimotor retraining. Cognitive functional therapy addresses the individual's beliefs, fear, lifestyle habits, and posture and movement patterns. And people engage in behavioral experiments similar to AT, and attention is given to all of these factors during those movements. And sensory motor retraining retrains how people think about their body and pain, how they process sensory information, and how they move. And in this approach, people engage in activities to improve proprioception. They engage in tactile acuity tasks, and those involve, for example, touching certain spots, and the individual has to determine where they're being touched, which is the ability that's impaired in chronic pain. Observation of different postures and mental rehearsal of those postures, and gradual progression to physical movement with an emphasis on smooth and fluid movement. And all of these are actually elements of AT. So this can give us some insight into how AT may be working to reduce pain. Here are some specific mechanisms that have been shown to be significantly associated with pain reductions in AT. The first is a reduction in overactivation of superficial muscles and in co-contraction, with a corresponding redistribution of muscle activity, as well as improvements in self-efficacy. And self-efficacy is strongly correlated with pain reduction and a reduced risk of disability due to pain. So here are some of the studies that provide this kind of evidence. Here's a study of Alexander technique compared to exercise for neck pain. And this study showed improvements in neck pain and disability for both Alexander technique and exercise, but the mechanism for each group was different. Only in the AT group were improvements in pain and disability significantly correlated with reductions in activation of the sternocleidomastoid muscle. Here's a small study on AT for knee osteoarthritis pain, and this study showed long-term improvements in knee pain that were significantly associated with reductions in co-contraction, in medial co-contraction of the knee. And these results are somewhat contrary to conventional strengthening approaches. The RCT of AT for neck pain that showed significant long-term reductions in pain and disability showed that these were significantly associated with improvements in self-efficacy. Here are some other potential mechanisms of pain reduction by AT. First, mind-body engagement, involving normalization of sensory motor processing, changes in postural tone related to normalization of excitability, learning, psychological effects, attention and reactivity, and touch. First, mind-body engagement. And when it comes to pain, it's known that rather than a body part, it's important to address the whole person, to engage mind and body. And AT does this by engaging the learner's mind in relation to their body and to the space around them. And this is done in a non-judgmental way. And this kind of accepting non-judgmental attitude has been shown to be associated with improvements in pain-related outcomes. So, for example, a practitioner may ask the client to notice specific body parts, such as the neck or the back or the knees, without any attempts to fix anything. And then the practitioner may cue the client to embody certain qualities, such as fluidity or freedom or expansion. The practitioner may ask the client to attend to the surrounding space in relation to their body, or to encourage certain spatial relationships within their body or between body segments. For example, the length of the back or the width of the back. These kind of embodied cues are referred to in AT as directing. An example would be to let the back lengthen and widen. And this kind of cue may encourage the individual to reimagine the configuration of their back, promoting changes in muscle tone and the overall postural state. And the client is asked to specifically to think the cue and not to do it, consistent with the idea that AT is promoting remapping rather than repositioning of the body. AT directing, guided by feedback from the practitioner, may engage and normalize body schema, those maps of where body parts are in the brain. This may be similar to sensory motor retraining interventions. These pictures down here are examples of some of the elements of that. And these approaches involve the tactile acuity training, mental judgments of body positions, and mental rehearsal of positions and movements. And these are also thought to address disturbed body schema. So Alexander technique may be doing this in a similar way. AT lessons often involve this kind of directing while performing a functional task, such as bending or walking. Here, as this person is bending, they may be paying attention to allowing the back to lengthen and widen and allowing the neck to be free. These kinds of tasks could act to re-engage and recruit disengaged body regions that have dropped out of working body schema. And this is something that occurs with pain. So likely this is normalizing sensory motor function. There is evidence that promoting embodiment of particular physical characteristics through manipulation of perception can address these sensory motor changes and be beneficial for pain. Here's an example on the left of a study showing that embodiment of a strong, wide back led to reduction in back pain. And here, the visual perception of the back was manipulated so that the person viewed their own back as a strong, wide back. And in a study, this one on the right, in this study of symptomatic knee osteoarthritis, illusion, also using visual reality goggles, illusion of resizing of the knee combined with tactile stimulation led to significant reductions in knee pain. So we've seen that pain can be changed by manipulating the perspective of a body part and embodiment with this latest technology. And AT may have been doing this for over a century. Changes in postural tone interact with changes in body schema, influencing and influenced by a number of other factors. Posture, again, requires adaptivity, adaptive yielding to forces and resisting of forces, and postural tone must be modulated dynamically for coordinated movement. Studies suggest that AT promotes adaptivity of postural tone. In a study using a device known as Twister, which you can see here on the left, that very slowly rotated people to measure axial resistance, found that AT practitioners had greater adaptivity in axial muscles over age-matched healthy controls. Specifically, on average, 50 to 52% less stiffness. And this is not due to a simple reduction in muscle tone, as AT doesn't aim to promote low tone or an overly compliant or floppy postural state. Rather, it also incorporates resistance. So as another example, in a study on spinal coordination, it was found that with a force on the back here, as you can see with this little stick figure, AT practitioners had more precise resistive response to this force on their back. So as they're being pushed on their back, the AT practitioners had a more smoother and more uniform increase in force, whereas the healthy controls were all over the place. And this is not due to stiffness, but rather to a more optimal distribution of axial muscle activity and reduced hip stiffness. And these results suggest that there's increased dynamic modulation of postural tone with AT. The Twister experiment was also done with people with low back pain, and you can see the actual device here with the person in there. And the subjects with low back pain actually had decreased hip and trunk stiffness after AT lessons compared to a group that had a convincing sham control intervention, which showed that group showed no change. And specifically, the AT group had a 29% reduction in stiffness after the AT lessons. And this reduced axial stiffness in the people with low back pain could underlie those observed reductions in back pain. So this study suggests that, or these studies suggest that dynamic modulation of postural tone can be enhanced with AT training. And even a few minutes of instruction in an AT-based approach to posture can increase this adaptivity in people living with Parkinson's disease. And Parkinson's disease is characterized by increasing rigidness. So in this experiment, people participated in 3 different conditions: a relaxed condition, a pull yourself up condition, and a lighten up condition. And the pull up condition was based on mainstream ideas about posture, and the lighten up condition was based on AT instructions. And the instructions basically went like this. For the pull up condition, people were told, gravity weighs you down, use your core to pull yourself up to your full height, engage the muscles of your abdomen and your back, stomach in, shoulders back, pull your head up, lift your chest, tighten your core. And in the lighten up condition, people were instructed to notice that you are pulling yourself down and give yourself permission to stop. Let your head balance easily at the top of your spine. Allow your spine to become uncompressed. Allow your torso to open effortlessly. Let your shoulders and chest be open and light. Imagine allowing your bones to send you up and your head floating at the top of your neck. And this study found that the AT group, the AT instructions led to reduced axial rigidity, increased adaptability of tone, reduced postural sway, and reduced lateral displacement while stepping. These same instructions also enabled young adults to smooth out and reduce postural sway. They helped older adults to improve static and dynamic balance, as you can see down here. And it's thought that this was possibly facilitated by reductions in co-contraction. Here you can visually observe the effects of AT in a pre and post test. This is the pre-test first of an up and over task, and then again following AT lessons. You can see that the trunk is much more stable. And then again, we can see the pre-test will be in the right bottom corner and the post-test in the top left corner. These same AT-based postural instructions focused on reducing effort for people with Parkinson's disease also led to movement improvements. For example, they had smoother step initiation, which becomes difficult in Parkinson's disease, a smoother center of pressure trajectory while walking, and again, reduced lateral displacement while walking. So this suggests improved motor control. And you can see the difference in the different conditions here in the center of pressure, as well as the lateral displacement. Another study found that AT practitioners are able to rise from a chair slowly without using momentum more smoothly than age-matched healthy controls. And here you can see in this computerized video of what happened in this trial. And you can see how the force applied in the AT is uniform and steady and continuous, whereas in the control, it's jumpy. It's inconsistent and it's jumpy, the way the force is applied, and there's momentum at the moment of takeoff from the seat. And high adaptability of muscle tone and low stiffness can explain this slow weight shift in this task of standing smoothly and slowly at a uniform speed over 8 seconds. Pain is often associated with extremely low variability of posture and movement, and also extremely high variability of posture and movement at times as well. And the optimization of this variability of tissue loading may be another one of the benefits of the sensory motor improvements that happen in AT. So here's an example of how lower stiffness and increased adaptivity of tone from AT may act to decrease prolonged static or inappropriate loading, including overly protective behaviors and bracing, for example. And this may lead to increased variability and improvements in body schema in a positive cycle. And normalization of neural excitability may underlie all these changes. Persistent pain, in a sense, is a learned phenomenon, and new learning can often help to reduce pain. Education in itself can be therapeutic, especially when combined with movement. And while approach and content vary widely among practitioners, generally AT practitioners provide education on awareness of physical and mental patterns that are habitual, whole body organization, and the processes involved in changing these. AT is primarily a learning modality. Also, graded exposure meaning gradual exposure to a movement or activity that is feared or that is painful. And this is a part of AT practice, and it's also beneficial for pain. So gradually being exposed to something to learn that it's okay to do. Expectancy violation refers to the disconfirmation of an expectation of pain or harm in doing an activity. And this kind of surprise at the ability to do something without pain or harm actually acts to enhance learning and to consolidate the new learning. People who are learning AT are often surprised by their ability to do tasks that they expected to be painful effortlessly and pain-free. They learn not to fear previously feared movements. And this provides the brain an opportunity to correct inaccurate predictions of harm while doing a movement. As reappraisals are made about the ability to perform tasks without pain, like bending, for example, predictions by the brain are updated and new associations are formed with stimuli that were previously associated with pain. For example, the act of bending or the act of rising from a chair or something that previously provoked pain. And these new associations outcompete the old associations with pain. All of these types of learning contribute to long-term reductions in pain. Here are some of the psychological effects that have been demonstrated in AT. Improvements in self-efficacy, fear avoidance, confidence, executive inhibition, sense of control and empowerment, self-care skills, psychological well-being, self-acceptance, optimism, quality of life, and the relationship with pain. And all of these are factors that are strongly correlated with pain reduction. And the development of certain cognitive skills can help to reduce fear and anxiety, contributing to a greater sense of control over pain. And improved movement performance and increased confidence can lead to a sense of greater self-efficacy and a greater sense of control and empowerment, and improved self-care skills are thought to reduce overprotection, the overprotection of pain. In a secondary analysis of that RCT of AT for neck pain, a high percentage of people in the AT group reported that they had learned to improve the way that they lived and cared for themselves as a result of their lessons. And this percentage increased between 6 and 12 months from 81 to 87%, reflecting the reinforcing self-learning nature of AT and the continued benefit of applying it. The AT group also reported significant long-term improvements across a total of 8 different self-efficacy and self-care measures compared to usual care alone, including the ability to put into practice what they learned, the ability to reduce their pain by applying what they learned, and they also made changes to exercise, relaxation, rest, and work. AT practice involves expanded awareness and enhancing the ability to consciously direct attention. And this is an ability that is impaired in chronic pain generally. And combined with this practice of directed attention is paired a practice of non-reactivity to a stimulus. For example, a practitioner may often instruct a client to attend more broadly than to the site of pain. And this can result in a distraction, of course, and a distraction does help with pain. But aside from that, this manner of intentionally redirecting attention and expanding awareness has been shown to help improve pain and functioning. And in general, mindfulness is associated with lower pain and reactivity. Brain imaging also shows that attention to cognitive tasks unrelated to pain activates pain inhibitory systems. And there's also some evidence that AT improves executive inhibition. So all of this suggests that AT could be reducing heightened pain sensitivity by reducing overall reactivity. In AT, non-manipulative touch is used as a sensory cue, drawing attention to a region while also encouraging that non-reactivity. It also provides feedback to the individual to promote changes in tension and in postural tone. For example, the practitioner may touch the client's back or head or hips or heels. And this AT touch invites adaptive and supportive postural tone. Touch has been associated with improvements in cortical reorganization, so it's likely that's contributing to remapping of the body. And AT touch likely improves tactile acuity, proprioception, kinesthetic awareness, or the sense of the body moving, as well as spatial acuity, where things are in space, as the individual is paying attention and not just being touched. It's not a passive activity. Like any other intervention, AT likely influences pain through some non-specific effects as well. And these may include, for example, individualized care, which has been shown to be important when addressing persistent pain. And AT is working with the individual where they are at in the moment in an individualized manner. The therapeutic relationship has been identified as a key component in any health improvement, including pain, and it's also a key component of AT. There's an emphasis on a caring, trusting relationship. The client and the practitioner are working together on shared goals, and there may be, in many cases, alignment with the client's worldview. So there may be immediate buy-in by an individual who has sought out this approach. It also promotes a sense of safety in the body, in balance, through improved balance and improved movement performance. Touch also has non-specific benefits for pain. And an active approach that depends on engagement by the individual has been shown to be more effective for long-term reductions in pain than passive treatments. And Alexander technique is an active approach. The individual is engaged in the activity in lessons, and that engagement initially comes through the decision to take lessons at all, as Alexander technique is generally not covered by health insurance. So the individual is making the decision to do an activity that won't be covered, and also engagement in exploration of different postures and movements and thought processes. So it's a very active approach. Finally, further research to better understand these multi-system mechanisms by which AT helps to reduce pain will help practitioners to optimize pain care and to better predict which individuals or which subgroups are likely to benefit from AT. We propose that postural tone and neural excitability would be fruitful areas of research and investigation into this relationship between AT and pain. Research on AT is challenging, as it is with all mind-body participatory practices. In the case of AT, due to the heterogeneity of AT teaching, as well as the inherent difficulty of studying postural mechanisms, because there is so much going on, and science is just beginning to discover a lot of those things that are going on. There's also difficulty in obtaining funding for non-pharmacological approaches. And in addition, trials of participative mind-body therapies face unique challenges in avoiding bias. So measures should be taken to increase the rigor of studies, including clear protocols, using appropriate comparison groups to distinguish non-specific effects and to limit confounding variables, and to use standardized reporting of standardized self-report, objective tests such as sit-to-stand, or function-related outcomes such as sit-to-stand, and tests of central nervous system related mechanisms. So in conclusion, there's evidence that AT reduces pain, and advancements in the field of pain science may shed light on the mechanisms by which that happens. Chronic pain involves plasticity of the nervous system, and modern pain interventions are addressing that plasticity. AT may share some of those mechanisms with those modern interventions, such as learning, normalization of sensory motor function, improvement in psychological factors. And AT may also have other unique mechanisms by which it's working. For example, sensory motor changes that are related to normalization of muscle tone, neural excitability, and tissue loading. It may also include alterations to body schema, as well as reduction in overall reactivity. Thank you very much. And I'll just include on the screen here, for in case anyone wants to look at it during the recording, of the references for AT-related studies.
Great. So feel free to type any questions or comments into the chat.
Okay, thanks for the questions. I'll see if I can respond to them as a whole. First, in response to the last question, are you aware of what you're doing, is a great question, because AT practitioners, which I am one, work with an individual by practicing the technique themselves. So AT practitioners develop the non-manipulative touch that is used through practice and learning of the technique, and working with an individual always involves working on oneself as well, to not only model that non-reactivity, but to help encourage that in the individual, and to not try to fix anything into the individual, but to help the individual to discover on their own how change can happen, to allow change to happen. So that's not being imposed, but rather it's a process of discovery that's being done together so that the individual is able to allow change, beneficial change, in this case, in pain. And how do we know? For example, some of the studies on back and neck pain that have been over a long period of time show that people have been able to reduce their pain. And qualitative studies, which are studies that involve interviewing people to find out what was important to them, what were their experiences like, have found that people are able to use their skills, that they find they're able to build skills that they're able to apply to their lives. So that's the sort of thing that people in those studies have said. And as you mentioned, it's a learning process. It involves increasing awareness of the body, and touch by the practitioner can help with that. In some cases, AT is also practiced without touch, and that involves verbal guidance. So it's increasing awareness of what's going on, with increasing ability to allow change to happen. And as a practitioner is working with an individual, the touch also gives information about the changes that are occurring. So you asked, how do we know if change is happening? One way that we know is through visual observation of changes in posture and movement, and on a quite subtle level. And touch also can give us that information of what's going on in terms of muscle activity. And I hope I addressed all those questions. Thank you for asking those.
We appreciate having you.
Thank you, everyone.